Benvenuti a tutti. Questo è Research Spotlight. Io sono Andrea Caffo. La puntata di oggi sarà in inglese perché abbiamo un ospite da Israele. Quindi da questo momento in poi la puntata sarà tutta in inglese. So welcome everybody. This is Research Spotlight. And I am Andrea. Today I'm delighted to host Dr. Michal Israel. Welcome, Doctor.
Okay, hi, hello. Thank you, Andrea, for the kind invitation.
No, thank you for being today here with us. It's a big pleasure for us. An honor to host you today. Today we are going to discuss Israel about what Kadimastem is doing to treat ALS. So we are going to follow a deck where Dr. Israel will present an overview of the content, then how the work is going on, and then maybe in the end, if time, we can have also some Q&A session if possible. Okay. So again, thank you very much for being here, and the stage is yours.
Okay, thank you, Andrea. So I will share the presentation. So you see it well, right?
Yes.
Okay, great. So here in Israel, we opened very nice biotech company with the first aim of doing or producing cells for treating any kind of a disease. And we are focused on two main cell types, which I will discuss later. So this is a small disclaimer. So the company vision is actually to replace, restore, and repair the functionality of disease and malfunction in cells in various degenerative diseases by transplanting healthy and functional cells. So how do we do that? We take very young cells, which are called pluripotent stem cells or embryonic stem cells. We use them as a raw material or a starting material. These embryonic stem cells, very, very young cells, can become any cell type of the human body because these cells can generate a baby. But we don't generate babies. We just take only the cells, okay, the tissue cultures. Andrea, please feel free to ask me for any clarification during, the talk.
Sure.
Okay, so we take these very young cells and we build up protocols or a method to differentiate or direct these cells toward specific cell types of the human body. So we can generate brain cells, we can generate lung cells, we can generate liver cells. But the company decided to focus on two main diseases. The first one is SLA or ALS. So for that aim, we are generating very special cells that belong to the central nervous system, which are called astrocytes. Okay, my brain and spinal cord and also yours brain and spinal cord consist of about 30 to 40% of astrocytes. And these astrocytes have many, many functions that support the neurons in the brain and the spinal cord. Other pillar or other program is generating insulin-secreting cells for the treatment of diabetes, but this is for another session. So this is the pipeline or the platform for the company. So as I said, we are focused on ALS. And in terms of regulatory or where the company stands, we did all the preclinical studies to prove that our cells are effective and safe. And I will demonstrate and elaborate on that later. And already we completed a phase 1-A clinical study in 10 ALS patients here in Israel. So it's a first in human study where we take the astrocytes, we call them AstroRx, and we transplant the cells intrathecally to the fluid that surrounds the spinal cord and the brain, which is called CSF or cerebrospinal fluid. And then we sew different results which prove that the cells are safe, and also we had some clinical meaningful efficacy results, which I will tell you later. So the company received orphan drug designation from the FDA. We had a pre-IND meeting like 6 years ago, but we decided to do the study here in Israel. And we hope to do by the end of this year, we hope to submit an IND for doing additional phase 2A clinical study with the AstroRx cells. So this program is progressing very, very fast. So in terms of ALS, I believe that you know a lot, even more than me about the disease, but I will share with you some scientific data. So in ALS, the motor neurons that actually innervates our muscles are dying. I all the time imagine the neural system like the electricity in your house. Okay, you push a button and you have the electrical wires, which are the neurons. And in ALS, once you push the button, sometimes the electrical neurons don't transmit the signal. So the signal does not reach to the muscles, and eventually the muscles are paralyzed, and there is a massive death of motor neurons and also of muscle fibers, which leads to a progressive loss of control on your muscles. To date, there are about 90 to 95% of the cases are sporadic with unknown familial background, and about 5 to 10% of the cases are with familial background, with somebody in the family having this disease. So I won't get into the details of the science, but there are all kinds of mutations which are related to ALS. Mutations means that there is some kind of impairment in the protein or the gene, and this leads in very high prevalence for ALS. In terms of disease onset, it's between 50 to 60 years, but there are younger patients and also older patients, and the survival from onset is quite low. So we have neurons which are dying, and as I said before, we have about 30 to 40% of our CNS, of our central nervous system, which compose of the brain and the spinal cord. We have these astrocytes, which their main function is to support the motor neurons and neurons in general in the central nervous system. So in ALS patients, these astrocytes were found to be malfunctioning. And when I say that they need to support the neurons, they do it through several ways, or as we call it, mechanism of action. So one way is by the secretion of all kinds of neurotrophic factors, which are factors that support the well-being of neurons and motor neurons, specifically in ALS. They fail to remove toxic factors. For example, glutamate, if it remains in the proximity of the neuron, it might lead to its death. So astrocytes uptake this toxic factor. And they also regulate oxidative stress by secreting antioxidant, and also it immunomodulate the immune system, which is part of the pathology of ALS disease. So we understood, okay, we have neurons, motor neurons, which are dying. We have astrocytes, which are malfunctioning. And here at Kadimastem, we know how to produce and manufacture healthy and functional human astrocytes. And we saw in vitro it means outside the animal or outside an organism, that these cells can secrete many neurotrophic factors. They can remove toxic factors such as I said, this glutamate. They can buffer from oxidative stress. They do immunomodulatory action. And it's very important to say that once you use cells to treat this disease, we act through multiple mechanisms of actions, meaning, for example, if you have drug, it acts through one mechanism of action, maximum 2 mechanisms of actions. And here we have a full repertoire of different ways that these cells can contribute to the survival of these motor neurons. So this was the main rationale of why we should use healthy and functional astrocytes instead of the malfunctioning astrocytes in ALS patients to support the death of the survival of the motor neurons. So, as I said before, we are taking very young cells, which are called embryonic stem cells or pluripotent stem cells. It's like a clay, the raw material, really, or the starting material. And we have, as I said, very special protocol or very special method to mimic the embryonic development and to manufacture just this cell type. In our body, we have more than 200 cell types, and we know how to take this clay and actually make the right cell type. So we have an off-the-shelf cell product, which we are developing these days. So we don't need to manufacture and wait for the supply of fresh cells. We are manufacturing off-the-shelf cell product of differentiated or committed astrocytes. And once we reach to the clinic or to our next phase 2A clinical study, we wish to thaw these cells near the patient bedside and then inject the cells intrathecally. When I say intrathecally, it's like, let's say, a epidural injection, you know, when there are pregnant women that are giving birth, and you have an epidural injection. So using these cells, we are inserting the cells deeper to the CSF, to the cerebrospinal fluid. And then, because it's in a liquid, in the CSF, the cells migrate. They migrate throughout the neural axis. They reach different levels of the brain, where you have your upper motor neurons, you know, all the functions and the orders that the brain sends to the muscles come from our motor cortex. Okay, so here are the upper motor neurons. So you want these cells to reach the upper motor neurons, the brain. And also you have the lower motor neurons. For example, if you have a neuron that sends axons that are let's say the electrical wires to the spinal cord, and then from the spinal cord to your muscles. So you want also the cells to reach in close proximity to the different levels of the spinal cord. So it will have an effect also on the lower motor neurons. So we show that once we transplant the cells intrathecally, these cells distribute throughout the neural axis, reach different segments of the brain and also the spinal cord. So it's more.
So sorry to interrupt you. The tablets are the cord and the brain.
Yeah, they reach different levels.
Okay, because so you want to upper and the lower motor.
Exactly. More systemic view, because there are different approaches that, you know, try to inject maybe locally to very specific region, but then you treat very let's say restricted a set of muscles. For example, if you inject to the lumbar or inject to the cervical region, you want to control maybe just respiratory functions or motor functions once it's lower. But once we use this approach, we want to have an effect on the entire nervous system, the entire motor neurons. Okay. So in order to first test it, we used an animal model, which is called the superoxide dismutase, which is one of the mutations also that is presented in human beings. And we injected very similar to the route of administration that we injected to human patients. And here we injected the cells through lumbar puncture, which is very standard procedure. Every neurologist and anesthesiologist knows how to inject the cells. And then we inject the cells to the CSF, and we monitor for the survival of these rats, the grip strength, the rotarod, and different functions that also in the clinical trial we can measure. So as you can see here, once we transplanted the cells intrathecally to these animals, we managed to delay the disease onset, meaning it was delayed. In addition, we prolonged the survival of these animals. Now, we need to remember that this animal model is very, 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 let's say, severe. So in this animal, once there is a disease onset, the animals die within 2 to 3 weeks. So any effect in this model is very dramatic, and profound, and project on a potential efficacy that might be in human beings. So we also looked for different measurements, such as the motor performance. This is measured by several tests, which are the grip strength, which measures the upper limb strength, the rotarod, which is like a wheel that animals rotate on that, and once they are weak, they actually fall. So we saw that once AstroRx were injected to these animals, we improved the motor performance of these animals in both assays, in the grip strength and also in the rotarod. And in terms of body weight, once you lose your muscle function, you also lose your body weight. So we saw very nice results also in maintaining the body weight, indicating that the muscles preserved their performance. So we did a very comprehensive work, moving, from an idea and manufacturing the cells. You are on mute, Andre.
No, sorry. I was saying this is one of the most important parts. Our patients are very interested in this human clinical trial.
Yeah, I know. Okay, so at Kadimastem we have a GMP facility. A GMP facility is a good manufacturing practice facility where there are 2 GMP suites where we manufacture the cells under clinical conditions. So the cells are manufactured in a safety way. So we checked all the safety profile in terms of any pathogen that could be inserted during our manufacturing process. And we also know how to identify our cells in very different set of tests that we do on our cells. And we have also what is called a potency assays, where we know that these cells are functional. So we transformed, all the ideas in the laboratory work towards clinical manufacturing of these cells. We did all the preclinical data that I just presented. And then we moved into our first in-human clinical trial using these cells, the astrocyte cells. As I said before, it was done here in Israel. And the study outline was as followed. It was performed in Hadassah and Karem in Jerusalem, which is very good hospital here. It was a phase 1/2 open label, single arm. We used 2 different doses of AstroRx cells. One is the 100 million cell dose. 5 patients were given with the cell dose. The other one was 250 million cells. So we have cohort A with 100 million cells injected intrathecally to these patients, and the other cohort B with 250 million cells injected. And we had what we called a run-in period, just to monitor the deterioration of ALS disease. We had several tests, such as the HHD, which is the handheld dynamometer, which measures the strength of the muscles. The most famous one is the ALS-FRS, which actually measures different types of motor performance. And we wanted to set up, how much the disease deteriorates in this run-in period. Then we injected the cells, and we monitored for the patients for a duration of 6 months. Then we had extended monitoring time just to prove that the cells are safe. So this was the first in human clinical study that we performed. And in terms of safety profile, because this is a new technology, okay? This is a new technology, new cell types, and we needed to prove, first of all, that we don't risk the patients, okay? And that the cells are safe, okay? So in that term, we monitored the patients for a duration of 1 year. And we saw very high safety profile with no treatment-related effects and no adverse events, which were related to the treatment in cells, and there were no dose-limiting toxicities. So we were very encouraged by these results. And then we looked for the efficacy data. Now, we need to remember that this is a very small number of patients, very small study. And any effect, if we can see any effect, it would be very encouraging for us. So here you can see the results that we analyzed, and we saw that after that we had an effect, a therapeutic effect for a duration of 3 months, which was very encouraging. And we had the same effect was observed in cohort A, the low dose, and also in cohort B, the higher dose, the 250 million cells, for a duration of 3 months. And once we pulled the cohort A and cohort B, we pulled together, we saw also very significant results of the efficacy data.
Mm-hmm. And just a question: the different A and group B. How can we explain this? Because the heterogeneity of the patient.
Yeah, so there, as we can see it in terms of the effect, we had very similar effect. Okay, there was a let's say I'd say the disease stopped or the decline was reduced. Okay, in a duration of 3 months. It's a small study, so there is a very heterogeneity in the population. So for cohort A, we had more earlier ALS patients, and for cohort B, they were deteriorating faster. But in terms of segmenting the effect of the cells, we could see it also in A and also in B.
Sure.
First, it's a small clinical study. It's encouraging results, and we must do another study just to confirm these results. And the other thought is, okay, if it works for 3 months, what should we do after 3 months? We should repeat the injection just to see if we can, stabilize the disease. This is only one parameter, the ALS-FRS, and we need to, to monitor for different parameters as well, just to see that the effect remains, and we have the, similar results also in other parameters.
So just to this was just one injection, right?
Yeah.
Okay.
Yeah.
Thank you.
Here is another type of analysis. We defined what is called the rapid progressor, patients that progress very, very fast, with a cutoff of 1.1 ALS score per month. And we saw very similar results indicating some clinical meaningful effect of the cells themselves. So, as we said, we found out that the cells are safe. We had a duration of additional 6 months follow-up. So we have a safety results for a duration of 12 months. And what next? What do we plan to do next? So in our next clinical study, we wish to do a repeated dosing of AstroRx cells to see if we can prolong the effect that we see by these cells. And now we are also manufacturing and developing off-the-shelf cell product. So it's going to be very easy to ship it worldwide and treat any patients in the world.
Wow, that will be amazing.
Thanks. So this is it. If you have questions, please feel free to ask.
Yes, the question now is you are planning to do second phase with the multi-injection in US, where are you planning?
Yeah, so we are planning to do the next clinical trial in the US under IND. Okay. We are now, developing all the clinical protocol, and we are considering also maybe having the study here in Israel as a sub-site for the same study that is done under the FDA. And we hope that it will work so well, so we can expand and do the advanced clinical study, the phase 3 studies all over the world, also in Europe, reaching Italy, and
Yes. And do you have any details already? Something that you
can you repeat it, because the line is not. Can you repeat the question, please?
Yes, if you have timing to share possible.
timing, when are we going to do the study?
Yes, when you are going to do
Yes,
this?
when are you going to do this?
Okay, so we intend to submit an IND, which is the investigational new drug product file, by the end of this year. I hope that it's going to be ready by November, December this year. And then we hope that we are going to be approved relatively fast, with no regulatory obstacles in the way. So I hope we can start the study within a year.
Okay, so
we are talking
2023 study.
The beginning of 23, yeah.
Next year, okay, beginning next year. And the other question is about the kind of protocol will be randomized, double-blind, placebo-controlled, or maybe trying to do another open-label study.
We are just developing, the clinical protocol, and we are also public company, so I don't know how much
Sure,
I can share.
no. Whatever is possible to share now.
Yeah.
For
So it's not going to be open label. We are going to have a placebo arm as well.
Okay, sure.
Hmm.
Okay. I think that's it. I mean, it was a date which I hope as well. We were hoping to probably earlier, of course, but we understand that you have your plan, of course. So I think that's it. We really appreciate your time, your speech today, and the details that you share with us are very, very promising, results. And we really support what you are doing. Somehow, as a advocacy community, we can do something to do. Simply ask, and we will try to do whatever we can. Of course.
Okay, so thank you, Andrea. So first of all, thank you for hosting us. We also wanted, everything to be faster, but we need to work, according to all the regulatory demands and proving that we are doing everything, by the book. So we'll do our best and work very hard to see how we can expedite everything and have it ready on time. Again, and thank you for the kind host and invitation. And we are very open for any collaborations. If you are in contact with researchers in Italy and you think there are scientific ground for a collaboration, please feel free to do the needed introduction.
Why not?
And we are here for any support that you need.
Perfect.
Okay.
Lovely. Thank you very much.
Thank you very much.
And I hope you also had a good Thank you very, very much. And see you next time.
Okay.
Bye.
Okay, and take care and stay safe.
You too. Bye.
Okay.
You too. Bye.
Bye.